This is Dr. Raj Chandwaney. This is a left subclavian artery chronic total occlusion intervention to treat angina and subclavian steal syndrome in a patient with prior coronary artery bypass graft surgery. I don't have any relevant financial disclosures. This is a 67-year-old woman with a history of coronary artery bypass graft surgery in 2020 and known right carotid artery occlusion, who presents with recent onset of class 3 angina, shortness of breath, near syncope, and dizziness. Her echo reveals normal left ventricular systolic function without any significant valve disease. Her myocardial perfusion study reveals moderate ischemia in the territories of the left anterior descending coronary artery and circumflex coronary arteries. Her medications include aspirin, clopidogrel, metoprolol, isosorbide, atorvastatin. Her past medical history remarkable for the coronary artery disease with coronary artery bypass graft surgery in 2020. She does have this known right internal carotid artery chronic total occlusion. Classic risk factors including hypertension, hyperlipidemia, a family history of coronary artery disease. Although she has a prior history of smoking, she's continued to use vaporized nicotine. Her physical examination is remarkable for the discrepancy between her right and left arm pressures. She has diminished left-sided radial pedal pulse. Her EKG does not reveal any Q waves. On cardiac catheterization, she was found to have multivessel coronary artery disease, a patent saphenous vein bypass graft to right posterior descending coronary artery, an occluded saphenous vein bypass graft to obtuse marginal, an occluded left subclavian artery, and a patent left intramammary artery to left anterior descending coronary artery with flow reversal that appears to be causing coronary steal phenomenon. This is an angiogram of the native left coronary artery that demonstrates the coronary steal phenomenon with blood and X-ray dye traveling up the lima to the left subclavian artery. Here you see the left subclavian artery chronic total occlusion that was expected based on that native angiogram. This is an aortic arch angiogram. In addition to showing the left subclavian artery chronic total occlusion, you'll also notice the right internal carotid artery occlusion here and flow reversal in that left vertebral artery that's delivering blood to that left subclavian artery. For the intervention, I approached the left coronary artery with a CLS 3.5 guide catheter. Bilateral femoral artery access was obtained. I engaged the left subclavian artery using an 8 French JR4 interventional guide catheter. This provides me with flexibility for rotation if the system should back out while trying to cross the chronic total occlusion. We utilized a glide advantage wire inside of a Trailblazer support catheter. Using that system, we were able to cross the length of the chronic total occlusion using our glide advantage wire and the Trailblazer support catheter. We injected X-ray dye through the native left coronary artery to confirm that our wire appears to be in the true lumen of the vessel. After advancing the Trailblazer catheter more distally, the glide advantage wire was removed and contrast was injected through that support catheter to again confirm that we're in the true lumen of the vessel. Then, we initially performed angioplasty using a 5.0 by 40 millimeter Evercross angioplasty balloon. I then deployed a 6.0 by 37 millimeter VisiPro balloon expandable stent. The proximal half of that stent was post-dilated using a 7.0 by 20 millimeter Evercross angioplasty balloon. The final angiogram revealed an excellent result in the left subclavian artery, now with antegrade flow traveling down that left intramammary artery bypass graft to the left anterior descending coronary artery and antegrade flow traveling up the left vertebral artery. In conclusion, patients with prior coronary artery bypass graft surgery who present with angina may have progressive subclavian artery disease as a cause of their symptoms when intramammary artery conduits are used. Coronary chronic total occlusion operators should also be familiar with peripheral artery chronic total occlusion tools and techniques so they can offer their patients the most progressive treatment options available. Thank you for your interest in this case.